final paper for this scientific session is paper number 23 under the rapid fire, Impact of HIV on the Prevalence and Characterization of PAD in Kigali, Rwanda, pilot study. And just as a reminder, just about immediately following the scientific session is the 1-hour outpatient-based lab session that I encourage everyone to stick around for. And this is presented by Dr. Dockery, and senior author is Dr. Alpert from Rhode Island.
Hi, thank you. This study was conducted in conjunction with the University of Rwanda, and equipment was donated by Unetics Vascular. Worldwide, the estimated prevalence of PAD is near 6%, impacting more than 230 million people, and with the highest burden coming from high-income countries. Although ABIs are a simple diagnostic test, there have been few studies conducted in African countries, and those that did had varying estimates of prevalence. Thus far, no studies have been conducted in Rwanda. Some fast facts about the country. Rwanda's population is near 14 million, with over 1 million living in the capital city of Kigali. The population is young, with only 4% greater than age 65, in part due to a genocide in the 1990s. On average, there is relatively little smoking, with only 1% of women and 7% of men consuming less than 5 cigarettes a day. Rates of diabetes, hypertension, and CAD are low compared to the US. However, rates of HIV are significantly higher at roughly 3%. Our study sought to estimate the prevalence of PAD in a naive population in Kigali, Rwanda, and identify risk factors in this population to assess for unidentified vascular disease burden. Our study was conducted at 2 community health centers and 1 district hospital to capture the first 2 levels of Rwanda's healthcare system. We conducted ABIs on patients over the age of 40 who are voluntarily enrolled. Less than or equal to 0.9 was used as diagnostic, and greater than 1.3 was inconclusive. Self-reported surveys were also simultaneously administered. A post-ad hoc analysis was stratified by HIV status due to the high prevalence of HIV in our population, in part due to HIV treatment programs at these centers. On average, the overall prevalence of PAD was 3.14% in our 859 patients. Over 20% had HIV, and these patients were more likely to be younger, with an average age of 54, and more likely to have inconclusive ABIs with an average value of 1.37. Patients with HIV were less likely to have diabetes and hypertension compared to those without HIV. However, rates of hyperlipidemia, CKD, MI, stroke, smoking status, and obesity were similar. We estimate that the comorbidities were actually higher in both populations due to lack of screening and diagnosis in the general population, which could be due to lack of contact with the Rwandan healthcare system. However, there were also lower rates of diabetes and hypertension in HIV-positive patients, which could be due to their linkage with the healthcare system for their ART treatment. However, it was hard to assess for the connection between HIV and PAD, as mostly all of the patients were on ART in the study. Overall, our study was limited by variability in research staff performing ABIs, and we are unable to perform TBIs or PVRs at the time of the study. Our survey results were also limited due to language barrier, lack of labs or EMR confirmation, and immediate loss to follow-up. The convenience sample was also likely unrepresentative of the population, as we had higher rates of comorbidities in our group compared to the Rwandan national average. However, we confirmed that PAD is prevalent in Rwanda with an average rate of 3.14%. This is consistent with the literature from other African studies. However, we found that rates of diabetes and hypertension were lower in patients with HIV, which could be due to underlying PAD or calcific disease from ART. Additional studies are needed to further evaluate this population and have the ability for TBIs, PVRs, and lab values. Thank you.
Do you or can you have any idea of the symptomatic status of these patients? I mean, we physiologically determine PAD is present with the diminished ABI, but it would be interesting to see how the actual PAD is presenting symptomatically and how it differentially affects someone's life in a developing country versus Rhode Island.
So we did ask patients that had an abnormal ABI about symptoms. About a third reported that a third were asymptomatic, a third reported claudication, and a third reported breast pain. However, based on the ABIs, we didn't have any patients with severe disease based on their ABI, so we estimate that this was in part due to a language barrier. It didn't exactly translate well, so we estimate that those rates were from other sources.
Bobby Boyu from the University of Michigan. First of all, congratulations. I know talking with you previously, this has been a big passion project of yours, so awesome work for what you've done. The question I have is about the recruitment of patients and how they came to present to the clinic in terms of, is this a sort of community-based clinic that they're presenting for all causes, and do you think this affected your detection rates?
Yeah, so the patients were presenting, so at the two community health centers, most of the patients recruited were for the chronic disease clinics, and then other purposes, so picking up medications or here for a broken arm or a broken leg. And then at the district hospital, they were there for a variety of studies, which could be imaging studies such as MRI or CT, also peri-procedural follow-up. So there is a range of different presenting patients, but we estimate that most of ours refer to the chronic disease clinics.
Thank you for your talk. Catherine Hawkins, coming from Minnesota. Did you distribute Dopplers from a funding source, or were these already available at the district level and higher, and was there any difficulty in getting resources to the study participants? Thank you.
So our equipment was donated by Unetics Vascular, which is a Rhode Island-based company. We were using formal vascular lab equipment, and we were trained by Unetics staff prior. And then when we got to the country, we trained the Rwandan staff members ourselves, but there was some variability due to unfamiliarity with the equipment.